thanks for joining out at ISS. My name is Deepan, and I'm a doctoral student from University of Pittsburgh, and it's a pleasure for me to introduce Maggie. She's from Florida, initially from Florida. She did her Masters of Occupational Therapy from University of Florida, and then she was at New York. In 2011, she joined TIRE at Houston, Texas. TIRE, sorry, thanks for correcting. Then she's been involved with brain injury and then with spinal cord injury and the specialty rehab team down there. She currently works with Permobil as a clinical educational specialist and is an ATP and an active member of IOTA and RESNA. Welcome. Thank you.
Hello. Can everyone hear me all right? All right. Who's excited? This is the last session of the day. Woo! All right. Stay with me just a little bit. I have videos. I promise. That's my favorite part of a lot of these presentations. So as was mentioned before, I was hired onto TIRE in 2011, which was not that long ago, and I started off initially on the brain injury team, and then moved on over to the spinal cord injury team, and through that whole time I was involved in seating and positioning. And I developed this passion for it, and so when I had the chance to come and leave Houston, I wanted to relocate to Nashville, so hey y'all. Welcome to town. But I got a chance to relocate to Nashville and work for Permobil. And so I do want to, in full disclosure, yes, I do work as clinical education specialist for Permobil, but I don't intend for this to be a Permobil commercial. My objective for this course was really to get you guys to start thinking a little bit differently about how we're prescribing power mobility. Because I know myself, I would get into what I would call a seating and positioning rut. I could basically fill out an order form for people, just check, 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 and then it was done. And I wasn't thinking about people as individuals, and I wasn't thinking out of the box. So I really do want to start, I think this is the appropriate venue for it. It's also really intimidating because you guys know what you're talking about. There's very few conferences out there that have so many people that are so passionate about seating and positioning in one place at one time. So I feel so fortunate to be up here. So following a brain trauma, there are several mobility complications, and that's in addition to cognitive disorders, things like not having orientation, attention, difficulty with problem solving, visual perceptual abilities, which we could spend another whole day-long course talking just about visual perceptual disorders, as well as motor and sensory impairments. And during the acute phase, right after injury, that usually is the time we see the most recovery. We hope these things just resolve themselves, and we work towards rehabilitating these certain impairments. And then after a little bit, we start to consider these disorders static, and we're just like, this is the way it is. But I do want to kind of shift our focus. A lot of my friends don't know what I do. They think, they're like, you talk for how long about wheelchairs? I'm like, yeah, it's not just a chair, but people have a view on mobility, and I apologize for the poor quality in this next clip, because I'm like literally on the TV screen here.
If the batteries went dead, you'd think she'd be able to roll it up that hill with her hands.
You think?
I mean, batteries have gone dead before. Aren't they prepared for that?
You know, most of them don't even have batteries.
Must have been one of those rich, spoiled, handicapped people who didn't want to do any work. Just wanted to sit in her wheelchair and take it easy. Well, I'm sorry.
And we all laugh because that's crazy, but people view it. People view it, oh man, you know, I don't want so-and-so to get in a power chair. That way, they won't work on walking. They're gonna lose focus on walking or they'll lose focus on propelling their manual chair. That's their exercise for the day. Holy moly, we need to really separate the idea of functional mobility and exercise. And we also have to separate the idea of power mobility only being simply a mobility device, just a way to get cognitively intact people with perfect vision from point A to point B, because they can be so much more, and we can use them as so much more. I want to challenge you guys to start in inpatient and in outpatient and home health and any way that, in whatever settings you guys are at, to really use power mobility as a therapeutic intervention. And I apologize for there's mild language in this next clip. If anyone's ever seen Workout Wednesdays, he's got a YouTube channel that's
This
funny.
is Workout Wednesdays. Here's what you need. Workout headband, workout shorts, workout shirt, workout shoes, workout socks, workout bells, house, from when you were a small boy. Let's do this. I am the one who works out. So the first thing you want to do is get out of your wheelchair and into your walker. Now, if you don't have a walker, it probably means you can actually walk. So you're already ahead of the game. I haven't used this since I was about 10 years old. How the hell did I stand up before? All right, now we are off and moving. Milestones are important because they remind us that no matter how far we've come, we will never convert to the metric system. Kilometer stones just sound stupid, and nobody wants to sing, and I would walk 804.6 kilometers, and I would walk 1/12 of a mile and be exhausted.
But yeah, and we laugh, and it is funny, and I suggest if you guys think this is funny, look up his YouTube channel. It's absolutely amazing. But we need to separate this idea of functional mobility versus exercise. I don't do squat thrusts to the bathroom. I would look awesome if I did a squat thrust wherever I went, but it's too exhausting. It is easy for the majority of us, and what we want to aspire towards is easy from point A to point B. And so thinking of a manual or even an ambulation as exercise, I think is the wrong way to do it. It's safe and efficient. It doesn't mean exercise is bad. No, exercise is good. All of us need more exercise. But the important thing is we can choose to exercise. And so it should not be confused with that. Just like that's a soapbox disclaimer. So if you are working with individuals that have cognitive impairments, early on success may be partial, inconsistent, really hard to measure, harder to write goals for. So hopefully during this we can get some good goal writing suggestions. Don't expect perfection. If we put all of our clients, especially ones with cognitive impairments, if we put them through an obstacle course, we are setting them up for failure. It's not just line following. And if mistakes are occurring due to fatigue or frustration, allow for a break. Switch to a different activity, especially when you're working with people that may or may not be super motivated to do power mobility. You don't want to associate negative feelings with the device. And so, have realistic expectations. This individual does have a brain injury, but he is at the PVA games doing very well at the slalom course. This is not what we are expecting on somebody's first evaluation for them to be able to reverse through a course, but it is something that we can aspire towards. When you're talking about any learning and mobility aspects, there's both intrinsic and extrinsic factors. Intrinsic factors including the cognitive processes, visual perceptual abilities, their spasticity, pain, age. Generally speaking, younger individuals tend to catch on to technology and learn new motor skills faster. Also, I don't even like mentioning this, men tend to do a little bit better at motor tasks than women. That's what the research says. I'm not making this up. And motivation. Motivation is critical. Motivation is so important. Somebody has to be motivated to move. If you are dragging somebody, including parents or caregivers, through this whole process, it's going to make everybody hate the process. Extrinsic factors, things we have a lot of control of, lighting, and it's not just about being in a well-lit, high-contrast environment. Sometimes, in order to make a motivating thing motivating, you may need to make the whole environment dim and light up where you want them to go. So modifying lighting to be appropriate. Also, be aware of the carpet. I would never suggest doing a first mobility task in a conference hotel room, because if you look at all the floors in every single conference center, they're insane. And you can't tell where steps are, you can't tell where anything in the environment is according to these carpets. Device parts, maybe the wheelchair is not fit appropriately for them, so that could also increase likelihood of disaster. Seating support, even how they're driving the chair, and we'll talk a little bit about this later, but the type of drive control interface that you are choosing has a certain amount of cognitive load and a certain amount of intuitiveness to it. So if we're picking the craziest system that we might do for our high-level spinal cord injury clients, that may not be appropriate for somebody that has a cognitive impairment. And you guys have a huge impact on what is going on, and the feedback that you're providing is a vital aspect that I don't think we really address very much. And I don't think I really ever, when I was doing any wheelchair training at all, took a look at how much feedback I was providing in a motor learning aspect. But we are teaching motor learning aspects when we are helping our clients drive power wheelchairs. So you've got to figure out what your main goals are. If you try to accomplish everything all in one session or all in 1 week, you're going to get overwhelmed. So you have to figure out where you want to start. With your client, are you just trying to establish the idea of cause and effect? Get them to associate the wheelchair with, this is something that moves, and I do this to make it move. Are you trying to actually therapeutically improve visual perceptual abilities? There is one, we'll go through that study, but there's studies out there that show that you can modify this by providing functional mobility throughout environments. Are you trying to provide that functional training, teach them to do very specific functional skills from within their home from the mobility device? Or are you maybe deciding to use this mobility device as a forced use or as an exercise thing? It's not that any of these aspects are wrong, it's just you need to know what you're doing in order to write the appropriate goals and to know what to expect out of this. And again, it's all nice and good when I have things on, black and blue and white up here, but we all know once we get into our clinics, it gets messier, right? Everything kind of intermixes and you're like, I don't even know what I'm doing, and you're rushing and there's daily documentation. But really do try to take a step back and figure out, okay, what am I trying to accomplish with this? Prioritize. Keep it simple. Don't overcomplicate it. Many times, a standard joystick is very appropriate for these clients. And so without trying them out with that standard joystick, don't go for that crazy midline mount joystick off the shoulder with 3 switches option. Start off with that and let that guide your next interactions. Of course, that's not appropriate for everybody, so if alternative controls are needed, try to determine that method as quickly as possible, because the more you're switching it around, the harder and harder it is to associate that with functional movement. And especially if you're trying to establish cause and effect, you want to keep the method of driving the chair or operating the chair as consistent as possible, as quickly as possible. If you're a new therapist or a new ATP to this industry, please rely on the experience of more experienced clinicians, because I know when I first started off, I call it like amateur OT hour. When I first started off and I had a client that had severe mobility impairments, I just kind of got doe-eyed and I was like, I don't even know where to start. But once you see that over and over again, you get such a better idea and a sense of, okay, this is probably going to work, this is where I want to start. So really rely on the experience of previous clinicians. When we're talking about choosing that drive control, this is just kind of a basic overall of drive controls. I'm going to breeze through this so we can actually get to the other part. But you got to find a stable and consistent location. Make sure you can mount it in a place that you want to mount it. You have to realize that movement quality has a significant impact on the drive control interface that you're choosing. Somebody that may have, just a very small movement of their finger, if it's gross, you're not going to be able to use a mini joystick. You're going to have to go with a switch, as opposed to somebody that's got very fine control. So knowing that movement quality is important. And range of motion, as well as in endurance and fatigue. I'm a big fan of saying if you get someone in a chair in the morning and they drive it for 2 hours and then they're too fatigued to do it for the rest of the day, that's ultimately a failure. We need to figure out flexible systems that allow them to be mobile throughout their entire day. And so before you're switching from the drive input device, so you've got something, it's not quite working, you're not sure why it's not working, make sure you have appropriate positioning and support. You need that proximal stability to get distal mobility. That includes even the head, so supporting the pelvis and the trunk adequately to get good head control. If you've positioned and supported as much as you possibly can, that's when you start looking at the input location. So perhaps the joystick mounted at the end of the chair is just not working. And granted, that works for 80% of people. It's great, we're used to that joystick being on the end of the chair. I think one time I made a goal. I was like, client will be able to reach to that standardly mounted joystick. And I looked back on that. I was like, why am I trying to fit my client to this chair? We need to be able to fit the chairs to our clients, so mounting that in a place that is appropriate for our client. And then programming. Who here programs often? All right, who here has never ever programmed a power chair? All right, we're about 50-50. Therapists, I'm a huge fan of if you guys want to get into it, great, that's awesome. You don't have to. If that's not your thing, that's okay. I do want you guys to know how, or not how to do it, but what the capabilities of the system are within a certain amount. So you know what to ask. And so you know, okay, hey, I'm having trouble with this, so we need to adjust this, and tell your ATP, tell your rep, those are what needs to change for it. And we'll talk about those things. There's proportional joysticks and handles. For the most part, adults at some point have used a proportional joystick to do something in their life, whether it's play crane or anything, a video game, whatever it is, they've used it. So there's a certain amount of intuitive factor to these. The second you move that proportional joystick to the chin, it becomes a whole nother bird. So if at all possible, through positioning things, try to keep it towards the hand if that's functional for the client. Then there's what I call weird proportional specialty input devices. I love them, they're awesome, they work great for a lot of clients, but they have different cognitive loads. Some of them are less. If you've got someone that has a brain injury that is very used to and is motivated to continue to learn video games, this becomes a very intuitive drive control for them. They get the idea of that proportional input and that they're moving themselves through space. Whereas the Vic finger control, where it works great for a lot of clients, it may not be super intuitive for someone to find that dead center every single time in this small box. And it uses these infrared lights to sense where your finger, or actually anything that you put in there, is located. So knowing just the different cognitive inputs. Also knowing where to even get these trials. I was a huge MacGyver fan, like in life and also as an OT. It was like there's nothing I can't do with thermoplastic material, foam, and duct tape. But there's no amount of thermoplastic material that can simulate a tablet control. You just have to have one. So making sure you're contacting manufacturers to get trials of these equipments for an extended period of time so your clients can really get used to the interface. And then there's other switch options, and there's many different types of switch options, and they take different amounts of force to depress. They also, some of them measure moisture content, like a proximity control. I wish I would have realized that when I was fitting someone for a head array that had dreads for like 25 years. It interferes with all the moisture. It just wasn't working. So knowing the method that these switches use can have a significant impact on the success of them. You have to know people's technology threshold. I think a little bit about my grandparents. I got them a laptop for Christmas, and I OT'd the crap out of this thing. I had like a button that was like, push to email Maggie. And here's how you go on the internet. You have the World Wide Web at your fingertips. Where do you guys want to go on the World Wide Web? And the first thing they did was check the local obituaries, which is so depressing. And of course, next Christmas, they gave it right back to me. They gave that same laptop back to me. They're like, we don't want it. It was too much for them. And when we put these crazy wheelchairs in front of some people, that's what they see. They see complicatedness, and they just want to give up. And I'm done. This is frustrating. And that's where you guys as ATPs and therapists really have to come in. It takes extra programming and technology knowledge on your part to make these easy, to give easy buttons to your clients. One common problem I saw all the time is my client would not be able to tell the difference between tilt and recline. And granted, I was dealing with mostly new injury clients that don't necessarily have a severe cognitive impairment, just someone that just can't figure out the difference between those two when it's their own body. So one idea would be modifying the task. You want to modify this and make it easy, so use some form of memory seating for them. Or maybe limit the amount of controls that they have initially until they get more familiar with the system, see the functional benefits of it in their home, and then re-allow that in there. Or you can facilitate learning, like bringing them in front of a mirror, or giving them little mnemonics to remember things. So I once had a little tennis ball suspended underneath the armrest, so that whenever they reclined, the tennis ball would go below the seat pan, and that's when she's like, I'm reclining. Okay. That was one way we figured out how to modify that task for her. So your initial programming parameters, you want to reduce the overall speed, but you don't want to make it so slow that they hit the joystick and nothing happens, so it has to be responsive. And that's where you need to understand how to modify acceleration and deceleration. So it's not the overall speed, it's just how fast you get there. An Audi A8 is gonna get to 60 miles an hour a lot faster than my Honda Civic. It's just the nature of what it is, and that's acceleration. So when you want to lower acceleration, maybe that's for somebody that's really tentative about this, or if it's a kiddo that practically goes into Moro response every time the chair moves. You might want to increase acceleration for your low arousal clients. So when they do touch that joystick, oh man, are they moving? They are moving fast, quickly, or at least they're quickly moving to the top speed that you allow them to do so. And then if somebody, let's say they're weaving all around, they're having a hard time keeping it straight, you may want to reduce the turning acceleration so it doesn't weave so quickly. These are things that you guys don't need to have, obviously, clients that have cognitive impairments to do, but you need to have a good understanding so you can apply it to all of your clients. And reduce power and torque. I did not know this was an option until I had one guy that kept falling asleep while he was driving his chair, like into the wall. He would just hit the wall and fall asleep and just jam on the joystick. It was burning all of our motors out. So we end up reducing the power and the torque, and that's how much power is actually supplied into the chair. So that now when he goes and hits the wall, the chair feels that resistance and times out and the motor shut off. You can reduce this down even more with pediatric clients to where it's not going to move that table all the way across the room before it stops. Will it reduce all injuries? Absolutely not. By the way, kids never crash. They interact with the environment. It's all learning. But you can do that within a certain amount. You'll realize once you start playing around with it, if you reduce it too much, it won't turn very intuitively. But you can do that. It won't go up ramps. It won't go off-roading, at least in that particular profile. But you can have that for training purposes for flat level things. So a couple, and the handout should be available online, so high power versus high torque situations. You may need to use multiple switches. Multiple switches are great for establishing cause and effect. But if you can hold off just a little bit longer, if you think somebody might be a long-term driver, sometimes it is better to just stick with the joystick and try to get that. If you think cause and effect, you're gonna breeze right through that, and you're gonna reach that milestone quickly, I might be more inclined to start with a joystick because there's a certain amount of cognitive load and we don't wanna switch it too often. I also hear this. This is my friend's typically developing child. Circles aren't always bad. She is gaining valuable information at that time. She's also very adorable.
Is anyone else getting
You
busy?
get so much feedback from that. And so we've got a case study here. He starts off first with switches. I don't know if you guys can see, but he's got switches right there.
And green. Let's go.
So he gets that cause and effect. He gets the idea of, okay, this is how I make this chair move. So we want to try him with a joystick. Is he perfect at it? Absolutely not. I think he's about 18 months. So this is still in process. I don't have like a final thing. This was sent to me like 2 weeks ago.
Do you want to come get my bubble?
So if anyone has got any really young kids or clients that do this kind of thing where you're like, I'm not sure exactly what's going on. Obviously, if that was the wheelchair evaluation, I'd be very hesitant to sign off on that. But I do believe he's got a lot of potential for this. And so we have to start rethinking how we get trials of chairs and how we help people out to be as independent as possible. I like what Ginger said before in the previous session. She said that as ATPs and as clinicians, we are meant for client-centered practice. And that's why we're here at these great shows here, to learn more about client-centered practice. We are not Medicare-centered practice. We're not Medicaid-centered practice, because those funding guidelines do not follow client-centered practice guidelines at all. So it's important to explore all the different options that we have. I'll cover a couple other programming options that I found to be really helpful with this population. You may only provide a switch in one direction. That's possible to do. It's in training mode and permobile stuff, but all the manufacturers have the option to limit that direction. You may inhibit a certain direction. With kids, they tend to always pull backwards. This is Andrew. He was participating in a research study back in 2009, and this is his first time in the chair. That's calming. You'll see, oh boy.
Oh my word! Where are you going? Oh no, okay. Wow! What? Say what? Where are you going? Oh, nice
So you can either,
Andrew.
and a lot of times, I don't know if anyone's ever tried that either, just put a kid already in a chair and they pull back and they're going backwards and mom is not happy. He's only going backwards. Well, yeah, but he's going. So you can either inhibit that backward direction and force that movement in the opposite direction, or you could reverse the joystick orientation and actually have backwards bring it forwards. I call it fighter pilot mode. So if we look at the wheelchair skills that are related to cause and effect, that's things like, these are goals that you could write, you know, able to operate the horn, able to turn it on and off. Maintaining contact with a joystick, you can measure that in a time-dependent variable. Say, we'll maintain contact with the joystick for 5 seconds. We'll do it for 10 seconds. That's how you want measurable stuff, because if we're not able to write measurable goals, we're not looking at the right thing, and also insurance companies aren't gonna see it if we don't. You want to look at where they're looking when they're doing that. If they're constantly staring up at the ceiling and they're not orienting to anything around them, that could be a goal. So they're going to look in the direction of where they're going, or that they're going to look at the joystick while they're doing that. And then the most difficult one, the stopping, first of all, without prompting, and then later on progressing that to stopping with objects. So with this, when you're establishing cause and effect, you want to keep your voice calm and reassuring. Use really simple action words. They're not going to know forward, reverse, around. They don't know that in many cases. You may want to start out in familiar environments. Some research says small familiar environments. I kind of like large familiar environments. And then this one, I can't really underline it enough. Please clarify expectations to caregivers. Sometimes I give them like a magic, programming dongle, and I'm like, if you're not holding this, no one talks. So making sure we're keeping it a nice, calm environment, and also establish goals. I don't think they're gonna complete an obstacle course today. Today, what I'm looking for is that they touch the joystick and interact and get some sense that they're moving, because that may be where you're at with this client. There's a study here that looked at cause and effect, and it said traditionally therapists use like single switch and simple computer games, or maybe something, an animal that moves, or a jukebox or something, to establish cause and effect. And only after that do they switch to trying power mobility for cause and effect. But they found it progressed faster if you progress the opposite way, or if you do them simultaneously at the very least, where even if they don't have cause and effect established, or they're not able to demonstrate that, to at least try out power mobility in that sense, because it's involving multiple sensory systems. So once we think about this, it makes a lot of sense. You're like, oh wait, you're getting optic flow by moving through the room, you're getting vestibular input, you're getting proprioceptive input. When you move, something moves directly related to that. So you're involving all these systems. You can throw in some bubble wrap and do some auditory input too. So you can do a lot of these things to really increase awareness and help to establish cause and effect. And then I absolutely love this chart. It's kind of defined the way I think about progressing individuals through power mobility and these phases of joystick use. And it's an ongoing study that it keeps progressing on and on as time goes. But they took a bunch of individuals and classified where they were in this joystick use phase. So the first phase, that you may get someone in the chair and they may not realize what the chair is capable of doing. They may not realize it is something that moves. They have no aim with their movement, and they may they may start crying. But eventually you want to move on to this idea where maybe they accidentally hit that joystick, and all of a sudden, just kind of like Andrew did, they're like, oh man, this thing does something different. So that's that idea of, okay, I did something to make this thing move. And then you get to this solid, this is what I kind of consider that kind of cause and effect milestone that we want to reach, is they know that every time they do that motion, or every time they hit that button or move that joystick, that the chair moves. They have no idea of directionality, really. They don't know how to do different movements, but they at least got action equals move. And so we'll see if Samantha here, we've only activated the right switch on the header array.
Can you turn till you see me, Sam?
I can turn it off for just right now, but we've only got the right switch activated. And I apologize for the poor fit of this. We later on worked on getting her to lean her head to the side, but in this instance, it just wasn't working out. And we did not want to mess with her once she was in there. The nice thing about activating the right switch instead of the forward and reverse switch, well, you only need 360 degrees. You can keep your hands off, and she can figure it out in her own time, and she still is getting a lot of information from that. So she clearly gets this idea of, when I move my head, it goes. And so I would put her in that stage 3. This is where the majority of our cognitively impaired clients get stuck, though. This is a really difficult transitionary area. And the first one is called chains of acts, and that's when you start to look at, okay, I can't just do one thing with the joystick and expect to get anywhere. You have to do multiple movements, whether it be, pull back and turn to the side in order to turn, or maybe hit multiple buttons. You have to do something else. It may not be efficient, it may not be really smooth, but the idea of directionality, and there's a difference between directions, is that fourth one. And the fifth one is when they start sequencing that thing together. It may still not be the most perfectly efficient thing, but they get the idea of starting to veer and go to different directional. It's more intentional movement to get to someplace. And so here's Samantha again. We've got all 3 switches activated. We'll see my colleague Amy, she's back there trying to get her to lean her head to the side where she's having none of it. You also see a really good indication of why a joystick wasn't working for her. She needs so much external support. She's really pushing into that in order to get the stability to even control her head. So that's that idea of getting that proximal stability before she gets distal mobility. So she gets the idea, she's got very exaggerated movements of the head in order to get her down the hallway. And then she's veering off to one side, so she stops and turns her head to the side in order to do that, helped by Amy. So she's turning her head to the side, which is what she was doing initially to get that chair to move. So that, to me, is putting her pretty much at a stage 4 on that level, where she's starting to get the idea of directionality. She's not efficient at it yet, but she gets the idea. At stage 5 is when I really want to start considering ordering a power chair for somebody, when they start getting that. And then these last 3 phases, they're critical for really having the chair and using it in a functional sense. It becomes less about, okay, movement for movement's sake, and more about what can I do for this to increase my independence in everyday life. And I spend quite a bit of time with power chairs, but I'm definitely not an expert. You have to be in the chair every day, all day, in order to be an expert and really, truly be an extension of your body. It's more or less subconscious movement of the chair. They did a study with this, and they took 45 individuals with profound cognitive disability. I'm talking IQ of I think it's either 25 or 30 or less. And they put them in power mobility. And they saw, over an extended period of time, how long or how far on this list they got. And a lot of people got to that cause and effect stage, which to me is still a therapeutic treatment. Does it mean they get one for themselves long term? Probably not. But I don't think it hindered them, and I think it's a beneficial therapeutic treatment that is involved with multiple sensory systems. But what's most surprising to me is the 8 individuals there with profound cognitive disorder that were able to get to that functional place, where they were able to use a mobility device to be more independent in their daily life. So I don't want us to underestimate our clients and assume that all of our clients, and these were not just children, these were children and adults from I think 2 to 18 that did this trial with. So don't underestimate your clients. So who has thought about the principles of motor learning anytime recently? Yeah, one person, but you're probably still in school. I can't see your face though. None of us think about this. We apply it somewhat naturally to a lot of, we think about NDT and positioning people, but we don't do it to how we're training people in this. And so I want to go a quick review over that because I think there's things we could change. I know reviewing my own actions, I definitely could have changed some things. There's a difference between explicit learning and implicit learning. We know explicit learning, that's more of that rhetorical rote memorization, here's how I place my walker, all that stuff. And then there's implicit learning, and that's what the user can see, hear, and feel. So that's feedback from riding a wheelchair, riding a bike, whatever you're doing, it's a lot more. And I put these slides in here so you guys think I'm really smart, because they use words like neuroanatomic isolation. But there is something that to be said about this. Explicit learning has this neuroanatomic isolation. If you damage a particular spot, like those studies with HM, those psychological studies with HM, you will see an inability to learn explicitly. And if anyone doesn't know who HM was, they did these studies where he didn't remember anything from day to day, but he generally they did a bunch of studies on him and he did better on chess games as time went on. So he was able to learn implicitly, just not explicitly. And that is kind of the senses of this. Implicit learning, there's not one, it's so widespread throughout the brain, there's not one area that is, or lesion site that's really shown to decrease an individual's ability to learn information implicitly. So our clients are able to learn. Especially following a CVA, most responsive to rehab efforts within the first 6 months. We know this. This is why we concentrate a lot of our efforts at this time. But regardless of the time post-injury, training has been shown to improve functional outcomes. So again, don't just assume everything is static and don't just assume that everyone should intuitively know how to operate a power mobility device if they didn't do it right the first time. And so we want to think about as well separating out motor execution versus motor learning, because it can be difficult. So with motor execution, you may have issues with where's the most consistent point of control, is it fine, is it gross, what's the reaction time? Whereas motor learning, you're going to see more difficulties with, okay, are they getting the idea of cause and effect? Do they get directionality? What about memory, executive functioning, and problem solving? And of course, none of these things really, I know these circles are really big, but really this circle is much bigger, right? Because there's usually more of both things going on. But being able to tease them out and know that can help you with your goal writing and even with the interactions that you have with your clients. I love this study as well. This one that found that active movement of the affected upper extremity helped to ameliorate visual neglect. So when they were using their affected extremity, they were more likely to attend to that side during that task. And granted, it was not driving a power chair, but these are things that we can start to apply in our clinics. Do a case study on it. You have free labor with OT and PT students. Give them this task. If we look at motor learning, depending on the area of the brain affected, different motor learning styles can be observed. So if you get an MCA stroke or something affecting the basal ganglia, people might not respond as well to explicit information, to you telling them tasks to do before you do the task. They may kind of shut down after that and just be like, this is too much. But it's the opposite with cerebellar strokes. Giving them very explicit instructions before and during the task can be really beneficial for cerebellar strokes. So we want to be really careful with what we're asking of our clients verbally, even in a very literal sense. We want to be careful of what we're asking our clients. Motor learning with memory deficits. Alzheimer's patients do demonstrate the ability to learn implicitly, but it's best in a consistent environment. So this is a really good benefit for individuals doing home health. With dementia, airless learning is the most effective strategy. If anyone's ever done airless learning, it's so much easier said than done. But the idea of it is that you don't let someone, you don't know exactly which motor pattern they're going to remember. So you want to make sure that every single time they do a certain motor sequence, that they do it the correct way and not the incorrect way, like trial and error, as we do with many of our clients. With Parkinson's, you can learn new skills implicitly, but the difficulty with retention of skills, they may not be able to remember from session to session. Again, best in a consistent environment, and tremor dampening as well as deadpan are two programming options that you'll want to be familiar with if you guys have any Parkinson's clients or any clients that have significant tremors. So visual impairments post-TBI, and I always, there's so many times that even in my own practice, I was just like, oh, visual neglect, not happening. Let's put you in the slowest possible device. No thresholds, no high pile carpet, that's cool. Let's just keep you slow so you stay safe. And oftentimes, what happens? They end up not pushing it around at all. They end up having a caregiver push them around all the time, which doesn't challenge the visual system at all. Knowing, and again, we could spend a long period of time talking about visual impairments, but knowing there's a lot of factors in this. The visual system develops the best with independent mobility. It doesn't develop as well with dependent mobility. We have to be actively involved in this process. I relate this mostly to navigational tasks. I don't know if anyone, is planning on going to the Wild Horse Saloon or whatever tonight. But if you guys happen to drive there, or you drive there, and then maybe too many drinks later, somebody has to drive you home. If that someone didn't drive there, I bet you they're going to want to use the GPS, because they weren't paying attention on the way there, were they? When we're not actively moving, we're not actively figuring out things, it's hard. I walked with a friend to figure out where this conference room was, and since I walked with a friend, I didn't remember where I was going. I had to re-find it out on my own, because I wasn't using those navigational tasks. So we took a case study here, and this was presented a couple years ago, but I think it's relevant for this talk as well. This individual was at a Health South 6 months post-CVA, and was in a manual wheelchair. They videotaped prior to and post the initial training sessions, and then did 10 consecutive days of 30-minute treatment sessions. Treatment sessions consisted of various different activities, the growth circles, figure eights, spatial orientation, especially that center alignment, and turning. These are the activities that were done. It was not done to the same environment as the videotaping occurred, because we didn't want to train specifically to the task in this situation. So his idea was he's supposed to come out here and turn down this road.
All right, come on, bud. Over here.
Does this look familiar to anyone? This looked pretty familiar to me. I was just like, see, this is why I told you, you're not ready. I know it. I heard my therapist's voice come on. Skip ahead a little bit. I love watching everyone's face when that happens. My favorite part of this. No toes were injured in making this movie. But she's using cues. She's cueing him. I'd say max verbal cues, almost meant to mon assist at times. This should be a big red X. Everybody's book, right? Oh my gosh, not safe. Well, there's an after video coming up.
Hey, one other thing too, we should tell him, Mr. Hoff, I want you to overlook to the left. So you really can tell where that curb cuts off, okay? Can you see it now? Okay. Overlook it. Look.
And This is after 10 days, 30-minute treatment, 10 consecutive days of 30-minute treatment sessions. Noticeably, the therapist is not hovering anymore.
What, you gonna stay on the sidewalk?
Anyone surprised?
Good job, Mr. Hoff.
I found this a little surprising. I was thinking, oh man, visual impairments, that stuff takes forever to figure out, to change.
James Cameron up there.
It's static, especially since if you look at what his, no, we're not gonna go for that one. If you look at what his visual field tests look, I mean, he's got some significant field cuts as well as neglect. So they did a pre-test here, and he didn't identify 195 stimuli. But the post-test 10 days later, he only didn't identify 156 stimuli. So they did see even an improvement even within 10 days of his visual field. Improvements were noted in cause and effect, avoiding hazardous situations with his attention. He scanned better to his neglected side. Speech therapists even reported he did better at tabletop tasks, vision and cognitive tasks. Furthermore, after this trial was discontinued, he lost those improvements. The speech therapist reported he had a decline in all those abilities. So it was that active using of functional mobility. Or one can extrapolate at least some of that information from that. And so it was an adjunct tool for visual perceptual defects. It can be an effective intervention tool. Was he a perfect power mobility driver after 10 days? No. No, absolutely not. But this actually put it on the table. It made him a candidate to even start considering this. And then there's other factors like, does he have appropriate support at home? Where is his discharge location? All that other stuff that we need to be considering. But this just even made it a possibility. It could be a constraint-induced principle. He was using those skills on a daily basis, which means they were more on the forefront of his mind. But shouldn't we be doing that for all tasks, not just standing and upper extremity use? Shouldn't we be trying to force the use of all of the deficits following brain injury, especially in that first 6 months, let alone further on in therapy? And there's even research on this. They looked at a study, they took 10 individuals, 6 of them had visual impairments following a stroke. And they did the wheelchair skills test, which we'll talk quite a bit about in a little bit, and they saw that with using these wheelchair training skills outlined in the booklet, individuals improved on average from 25 to 71%. So they scored 25% at the beginning, and then towards the end, a 75% on these. Both groups improved, although to note, the visual spatial group started off lower and ended up lower. You still see improvements when you do these specific training tasks. And so I do want to encourage you guys, please go ahead and check out this program, the Wheelchair Skills Program. They've got a great resource for training in both manual and power chairs. They talk about motor learning concepts, lesson plans, games that you can do with individuals. It's a really wonderful free resource out there for you guys to utilize. So to kind of briefly go over some of the training principles, I won't go on too long because I'm running out of time, but we want to think about all these different motor learning principles when we are working with our clients. Of course, we need to do a demonstration beforehand. Focus on what you should do instead of what you shouldn't do. Observation alone is oftentimes not very effective, but if you follow it by practice, that's going to be the best method of doing it. Your session goals, speed versus accuracy. Focus on accuracy first. Practice doesn't make perfect. Perfect practice makes perfect. Early on in training, you want to focus on the movement itself, or you don't want to focus on the movement itself because that can be a distraction. Just focus on the overall tasks. And as skills become more automatic, that's when you can really hone in on individual skills. With verbal instructions, keep calm and shut up. As therapists, we're really good at talking. We picked a profession that is basically dealt around us talking, but too much information can be overwhelming and even detrimental. I made it PC for anybody offended. For anybody that may get overwhelmed by that. Verbal cues during the activity should be short. Sure, use very precise words and phrases, don't overtalk things, and certainly don't try to carry on a conversation if somebody's going down the hallway and trying to concentrate on visual stimuli until they're at that level. And that's a great activity later on if you're working on decreasing distractions. With feedback, feedback can occur with motor learning in many ways. It's not just actually performing the task. You can augment feedback, and I think of these, kind of golf training courses when you're done on the course, you want to figure out what's the next step, how do I get even better? You can augment that, and within wheeled mobility, thinking of doing tasks in front of a mirror, watching a video of you completing a particular course, biofeedback, or as feedback from you is another augmented feedback, but you don't want to give someone too much feedback all the time because you don't want them to be dependent upon it to complete the task. So just being careful about it. Don't give feedback statements no more than 2 times, or after every second attempt. This is very hard for me to do. I will admit this for a time. I'm like, this is what happened. Let me tell you all about it. But try to limit that feedback. Less talky, more practice. That's the other one. And don't be a Debbie Downer. Positive reinforcement is ideal, but it shouldn't be, life-changing, amazing, everything is sunshine and rainbows feedback either. That's another thing I have issues with. So making sure that you're decreasing the frequency of all of your positive reinforcement. And then there's the concept of consolidation. And I think this kind of hit home to me as one of those things that I definitely could be applying in my practice every day. Long-term retention is, of course, the goal for any of us that are learning these wheelchair skills. But if we're going to introduce a new skill, don't introduce another new skill right after it. Give at least 4 to 6 hour period between learning different skills, or ideally a nap or a sleep. That allows the brain to kind of consolidate. If any of you have ever tried learning an instrument or anything like that, if you try to learn too many guitar chords at once, you're not going to remember any of them. But if you start with 1 or 2 chords, learn those chords really, really well, sleep on it, practice them, and then the next day try to add in another chord, you have much greater success. The same thing goes for wheelchair skills. Offline learning, I love that phrase. And once a skill is acquired, it's important to practice it in different environments. So branch out, get this skill covered. It may be better to spread the training out over a longer period of time, but too much time in between sessions can cause a regression as well. So it's finding that just right balance. This is from the wheelchair skills test version. It's good to structure the therapy session with a warm-up, practice the skills that were accomplished during the previous session, and then that's when the new skill can be introduced. And then a cool down activity. Make sure, again, that we want to minimize frustration. The point of this is not to frustrate you and your client. The point of this is to provide functional mobility for somebody. So if you see they're fatigued, frustrated, just jump right into that cool down activity. Oh, I went backwards, whoops. So these are the individual skills that are listed in the wheelchair skills test. So there's a lot of different skills. Another version would be Jan Furumatsu's study that was done in '96. This is the pediatric powered wheelchair screening test. It's not that everyone needs to be pediatric to use this. I love using this resource actually just for good goal writing. It just gives you an idea or more ideas of goals that you can be writing that are measurable. And able to be effectively applied in your practice. So a couple different task kind of specific items. Again, know how to adjust speeds and accelerations. Observe how they're contacting the joystick. So many of my clients, even without cognitive impairments, would grab the joystick with the tips of their fingers. And they wouldn't get a lot of control of it, and they'd feel it's jumping around and very difficult. Even the simple idea of, okay, let's move it to the web space. Let's try to figure out a better way to do that, or change the interface. And the most important part of driving forward is actually stopping. So the way you would want to do that is actually modify how close people are stopping to different sized objects. So you can start with, okay, how close, and pick a bolster. Pick something that they can hit, and it's not going to, break a toe. Not everything has to be a column or a wall. So you want to progress from tall to short obstacles and do that. With turning, you want to start with small changes, moving around, wide obstacles, before you want to just start doing, doorways and sharp turns into things. You can break them into different parts or focus on getting the task more smooth. With maneuvering sideways, this is like parallel parking, getting ready for transfers. This can be a really difficult thing. I love one of them that they suggested in the wheelchair skills test booklet, that you use bubble wrap and progressively, before and after, and so long as they don't hit the bubble wrap, they're within that area. And that's measurable. You can measure that literally with a meter stick. And then eventually you can increase speeds if that's appropriate. Navigating through doorways is huge as well. You can use bolsters to progress the narrowness of it. Technical difficulties. I'm pretty much done anyway, but let's see here. Guy on me? Does anyone have any questions while I'm figuring out technical difficulties? I believe it was wheelchair skills test manual.ca. I'll pull that up in a second. What was it? Wheelchairskillsprogram.ca. I think it's on mine end. But we're back. Yeah, it's just as soon as you show up, we're good. All right. Let's see here. I say we're back. So if someone has difficulty maintaining that midline position while they're driving down a hallway, again, bubble wrap is fun. It provides an auditory cue without scratching up drywall or scaring somebody. You can decrease that turn acceleration so it doesn't turn so readily when they move their hand, especially if they have tremors or there's some motor dysfunction occurring. If their hand is slipping off the joystick, we kind of already talked about this, but moving it to changing the web space or modifying the control interface are two things you can do as well. So to summarize, visual, cognitive, sensory, and motor impairments really they affect your prescription. A lot of times we rule out clients because they have deficits in one or more of these things. But I think we can be doing more, and I think we can be using powered wheelchair as an adjunct to treatment to help out with these processes, as well as providing specific training skills to help people get to the place where they can be functional with these devices. So individuals with brain injury do tend to see responses when you do specific training. So, any questions? Yes. I don't know if there's somebody running around. It's kind of a big room. Does anyone have microphones? Sorry. Sorry.
I just wanted to know the frequency of the training sessions that showed the increase from 25 to 71%.
Oh, the mountain study. I'm trying to remember. I believe it was fairly consistent. If it was not every day for a half hour, it was probably 3 to 5 times a week for a good amount of time. I can look that up and get back to you, though.
Okay, thanks.
Everybody just ready to head out? All right, awesome. Well, if you guys have any questions, please don't hesitate to come find me. Don't leave quite yet because we got to give you the course completion code, and thank you guys so much for your time.